I am Dr. Jeslee Ann Jose, lecturer from the Department of Conservative Dentistry and Endodontics, Yenepoya Dental College, and I am here to present a class on Enlight to Cure, which will summarize or will enlighten you about the light curing units. So many times we encounter light curing unit in our day-to-day basis. With the advent of composite restorations, light cure is an unavoidable key to our clinical practice. Many times when we use a light cure, it is this blue flashy light that comes to our mind. And with respect to the tooth will be always thinking, why is this so bright? Why is this bright light coming onto me? Now, let us go in detail about the light curing unit. So these are my contents. The specific learning objectives of this session will be to know the science behind light curing unit, to understand the evolution of light curing unit, to have a thorough knowledge of the variables affecting and also its clinical implication. So why light cure? Now, light cure is an unavoidable part of the composite restoration. Composite restorations can undergo polymerization reaction for its chain propagation. And this polymerization reaction can be initiated with the help of a light or a chemical activation. And for the light activation, that is where we need to use a light curing unit which is going to activate the photoinitiators present in the composite resin. So, light cure helps in creation of an active free radical species which is going to initiate the polymerization reaction. So it is going to attack the double bonds in the monomer and it is going to help you in the conversion from monomer to the polymer. That is from the double bond to the single bond. That is how the polymerization reaction initiates and thereafter propagates. So before knowing it, we need to understand a little bit of the science. Okay, so light itself has got the electromagnetic spectrum which comprises from the atomic radiation to the electrical power. So it has got a variable spectrum of energy and it is the visible light that we are pertaining to when we talk about light curing units. So light itself travels with an upper crest and a lower trough, that is one length of a wave, that is what we call as a wavelength, and the number of waves that is traversing in 1 second is called as a frequency. So lower the frequency, longer the wavelength. Now, what are photoinitiators? Basically, they are the ones that is present in the composite restoration and it can be of two types, type 1 and type 2. Type 1 is basically the photoinitiator that itself, when subjected to light, converts into free radicals directly, whereas type 2 initiators are the ones which will get converted into an intermediary compound and that further creates free radical which will initiate the polymerization reaction. Examples for type 1 initiator is iocerin, which is a patented germanium derivative and it has got a wavelength between 390 to 445 nanometer. And examples for type 2 initiator is the camphoroquinone, which we all are familiar to, and TPO, that is trimethyl benzoyl phosphine oxide, and PPD, that is phenyl propanediol. Coming to the aims of light curing. According to Davidson and Diggy, we have to achieve a uniform and high monomer conversion to the full depth of the resin-based composite restoration. Also, achieving this within a shortest possible exposure time is very essential. At the end of the polymerization reaction, we should have a very low shrinkage stress. So all these three are the main aims of light curing. So in this table, we can see various photoinitiators. And what I want you to see is the absorption range of no two photoinitiator is in the same range. So a single photo light curing unit which we will have is not going to help you to cure the photoinitiators that are present in the various composite restorations which we use on a day-to-day basis. So the light curing unit should always have a range of wavelength. Let's familiarize with few terminologies. Many a times we think that the light which comes out of the light curing unit, the moment we press the light curing unit, is the entire light is going to come to the composite dressing. But the fact is no. The radiant energy is the energy that is being produced from the light curing unit as and when you switch it on. So it can be described in terms of joules. Now this entire radiant energy is not going to traverse all through the source till the tip of the diameter. So again the light is going to get scattered, and what reaches at the tip of the diameter is called as the radiant excitance. Coming to irradiance, that is the radiant power on the surface and what the resin receives. So what has been generated within the light curing unit is not reaching up to the tip of the light curing unit. Again, when it is being received by the resin restoration, again some amount of scattering is occurring. Spectral irradiance is the irradiance received by the resin at each nanometer. So the farther you place the light curing tip, there is going to be more amount of scattering. Now let's see the evolution. Now light curing units have evolved from quartz tungsten halogen lights to plasma arc curing lights to argon lasen light curing unit and LED light curing unit. Quartz tungsten halogen, these were the pioneers in the light curing unit. So these comprises of a tungsten filament which is enclosed in a clear crystalline quartz casing filled with halogen gas. It took almost 40 to 60 seconds to cure it, and it had a lot of heat generation. Hence, there was an inbuilt cooling fan which was fit within the light curing unit, which made them very heavy. Then came the plasma arc curing. So this had two tungsten rods encased in a high pressure envelope of xenon gas having a sapphire window through which the emitted radiation escaped. It had a very short curing time and it was widely used for bleaching, but then this sophisticated instrument or equipment made it little complex for the treatment. Then came the argon laser light. So here it was again used for vital bleaching, and it emitted longer wavelength of light which was nowhere in the range between the photoinitiators like camphoroquinone which was present then, and it was again expensive and heavy. The latest of all is the light emitting diode, wherein we had the blue LEDs, that is indium gallium nitride. It had low power batteries without any filament and no optical filter. It had greater photon generating efficiency, easily battery powered, and it used the semiconductors. Again, we have various generations. Coming to the first generation LEDs, they had inbuilt small chips of LEDs which were of low power of almost 5 watts. So they had to incorporate almost 8 to 64 chips of 5 watt to get the actual irradiance. So they had to incorporate a modification in the tip, that is called as a turbo tip, wherein the tip diameter at the source is larger and the tip diameter at the tip of the light cure, which is going to touch the resin, is narrower. Again, they use the nickel cadmium batteries, and it had a memory effect. Memory effect is nothing but they had to be charged for longer time for it to get battery operated, and also the charge used to get drained off immediately. The disadvantage of the first generation LEDs were that it could not incorporate the range of wavelength of the various photo initiators. Then came the second generation LEDs. Now coming to the second generation LEDs, here instead of the microchips, they had incorporated 4 chips, which each of which contained 4 bars. So total 16 bars were there, and they all were of high powered ones. Again, the problem of memory effect was overcome here, and they used nickel metal hydride batteries. Again, the wavelength was not of a greater range. Now next came the third generation LEDs, or what we call as the polywave technology. So As and when the aesthetic restorations progressed a bit, we had to incorporate various shades in the restorative materials according to the color of the tooth and aesthetics. So manufacturers started to incorporate a various photo initiator within the composite resins. So using a single light will not help you to cure all the photo initiator that is present in the composite resin. So that is when we had to use a third generation LEDs which incorporated more than a single light. Hence they had to incorporate a variable range of wavelength. So here in this picture you can see the ultradent light curing unit which had a total of 5 lights, and the center one emitted a violet light, whereas the 4 chips which is surrounding the central light emitted violet light. So there is going to be a range of wavelength. In this you can see there are 4 chips, each of it contained separate wavelength. So the upper left and the lower right lights emitted a wavelength of 460 nanometer, whereas the chip which is on the upper right emitted a shorter wavelength which is 445 nanometer, and the lower chip emitted 400 nanometer. So the advantage is any photo initiator present in the composites which is between the range of 400 to 460 nanometer can be easily cured with this light cure. Same example, same thing in various other examples. So initial Radi Plus had same wavelength of 450 nanometer all over, but when it came to the blue phase, we had a range from 410 to 460, and Valo codeless had a range of 405 to 460. Again, they made slight modifications in the tip, that is a pencil style body and a gun style body. So gun style body again had as a slight modification, that is the turbo tip which I already spoke about. Now towards the 4th generation, they had inbuilt programs which was set in the LED light curing unit, and here the same light curing unit can be used for various clinical implication. So here you can see a red ring. So the red ring indicates the active tip diameter. Now whenever you use a light curing unit, not the entire restoration is being covered by the light. So the area or the diameter which will be covered by uniform beam profile, that is called as the active tip diameter. So for example, when it comes to the 4th generation LED, the blue phase is an example of it, and the same LED has got various programs like a 3-second cure program, turbo program, high power program, pre-cure program. So all of this is already set in the light curing unit, and we can change the program and use it according to the various clinical implication. Now let's check the factors that is going to affect the light curing unit. We can attribute them to the core factors, wherein C stands for curing light, O operator techniques, R restoration characteristics, E energy. Now curing light, as I told you, the light curing unit should always have a range of wavelength to initiate all the photo initiators that is present in the composite resin. Operator technique, we cannot use the same technique for all sort of composite restorations. That is, if you are using a bulk fill technique, we need to change the curing protocol, and also if you are using an MOD cavity, that is a mesio-occlusodistal cavity, we will have to go for a multi-stage curing. Coming to the restoration characteristics, if it is a darker shade of composite, it has got a lot of opacifiers and we will have to increase the curing time. Coming to the energy has to be of a uniform profile, and uniform energy has to be distributed all throughout the resin restoration. Now let's check what is soggy bottom phenomenon. Many a times, due to the lack of chair side time, we will always try to do a restoration quickly. So here we may use a composite restoration material which is actually meant for incremental technique, wherein you have to incorporate 2 mm of the increment and do the restoration. But if on the other hand, if we increase the increment size by 4 mm or so, and we condense it to the cavity, and then we try to cure it with the light curing unit, what happens is that the surface layer gets cured faster, but the material which is beneath the surface layer will never get cured. So that part will always be soggy enough, and it is also going to cause marginal leakage and ultimately dislodging of the restoration. Also, it is going to affect the bone strength of the restoration. Also, one point which we need to see here is, when we are going for a class 2 restorations, we have to always place the light curing tip as close as possible and with the tip parallel to the long axis of the tooth and without any angulation, because the adjacent tooth marginal ridge can always hinder the light reaching up to the gingival seat. Now let's see the various curing techniques. Curing techniques can be of 2 types: continuous curing technique and discontinuous curing technique. Continuous curing technique again is subdivided into uniform continuous, high energy, pulse cure. And under discontinuous curing technique we have pulse delay. So what do you mean by soft start? Initially when we start curing, we will not intend to go for a high intensity light. Instead, we will go for a low intensity light and gradually we will step up the curing. So here the main advantage of doing that is that we are giving some time for the internal polymerization stresses to get relieved out. So that is the main intention of going for a soft start technique. Coming to pulse delay technique, here the polymerization is initiated by a short flash of light which will be followed by a waiting period of some minutes before the final cure. So initially we will go for a low intensity light, then we wait for some time and we allow it, that is the internal stresses, to be relieved out, then we go for a high intensity final output. So these are the graphical representations of ramped cure, staged cure and pulse delay. Now let's see about the beam profile. In this picture you will be able to see 2 types of beam profile. One with the green color is a uniform beam profile, though the intensity is only, though the power is only 1100 megawatt per centimeter square. It ensures that all the surfaces of the restoration has attained the uniform beam profile, whereas the non-uniform beam profile is where the profile may be higher, that is 1600 megawatt per centimeter square, but then not the entire restoration is receiving the same profile. Centrally it might go for a higher intensity and towards the periphery it will have a lower intensity. So during that time what happens is that we might get hot spots and cold spot. Hot spot is the area which is receiving higher intensity of lights, and cold spots are the areas in the restoration which is not at all receiving the adequate uniform beam profile, which intent leads to dislodgement or fracture of the restoration. So on an average the irradiance should be at least 1000 megawatt per centimeter square. Now as we all know, light curing always releases, it is an exothermic reaction and there is definitely going to be temperature changes. So the factors of the temperature changes can be the bulk of the material, irradiance, rate at which the resin based composite restoration is polymerizing, and we can use various things like thermocouples, thermistors and infrared thermography to analyze it. Now blue light hazard. Our eyes as well as the eyes of the patient is always subjected to the hazardous effect of the blue light that comes from the light curing unit. So it is very important for the clinician and the patient to cover the eyes with protective eyewears. It can be amber colored eyewears, and it is said that maximum permissible cumulative daily exposure to the blue light can be only up to 6 seconds. Now, how to check the intensity of the light curing unit? Now, many a times we purchase a light curing unit and then we think that okay, it is emitting the same intensity whole throughout, but that may not be the situation. It is always imperative to check the intensity once in 6 months, so that we make sure that it is a uniform intensity that is being emitted. So, we can check with either a dental radiometer or indirectly using bone strength. Now, so we always want to have an optimal curing time. Now, what are the problems if we tend to over cure? It is going to liberate a lot of heat and cause pulpal and soft tissue irritation and also a longer chair side time. If it is under curing, it is going to affect the mechanical properties of the restoration, lesser color stability, leaching of the unreacted monomer, pulpal and soft tissue irritation, and also recurrent caries. So, coming to the best practice, always inspect the light curing tip if it is clean enough before you start with the procedure. Always try to put infection control barriers, that is plastic sleeves, within the light cure, so that when you change the patient, when you use the light curing tip from one patient to the other patient, you are not going to transmit any infection. And it is very important to protect our eyes using the amber colored eyewear protection. It is very important to keep the light curing tip as close as the restoration, so as to ensure uniform light. And never keep the light curing tip angulated. When we are doing a restoration which is involving more than 2 surfaces, we should always keep in mind to do a multi-staged curing rather than finishing the entire curing in one shot. Coming to the best practice, we should always choose the light curing unit which matches the photo initiator present in the composite which we are going to restore with. And prior to the use, check the tip for cleanliness, ensure the infection control barrier is placed, and always position the tip as close as possible. Ensure that the active tip is covering the entire restoration. When you choose for a darker shade, you should always keep in mind that your curing time also has to be increased, because darker shade contains a lot of opacifiers. So, without increasing the curing time, you might end up with a soggy bottom phenomenon. Always make sure that your intensity is checked using a radiometer and using a light blocking glass, that is for the protection of the eyes. So, with this I would like to summarize today's presentation, and the key takeaways are: it is very important to know the science behind the composite resins. So, working with the light activated restorative materials requires profound understanding of curing process of the materials used and the factors which influence the outcome. So, depending on the choice of the material, be it fast or slow setting, initiator chemistry, and the clinical circumstances, that is the cavity size, location, or the preferred restorative technique, the dentist should be aware of the change in the protocol, that is curing protocol. So, we need to combine the time, power, wavelength depending on the type, shade and the increment thickness of the material, and we need to choose the best curing protocol so as to meet the aims of reducing the polymerization shrinkage, thereby ensuring optimal polymerization. So, with this I would like to end my presentation telling that always know your curing light and choose it wisely when you are using the composite restorations. Thank you. These are my references. Thank you all. Have a good day.